Okay, so now we're going to start with some cardiac meds. In this particular lecture, we like to focus on cardiac glycosides, antianginals, and antidysrhythmics. Before we get started on those, we have to talk about heart failure. We want to talk about a few things with heart failure, and the fact that heart failure makes a person really susceptible and really fragile when it comes to fluid. So when we're talking about giving someone fluid that has heart failure, you want to make sure that we're giving less fluid than the normal person, and that we're giving it a whole lot slower than we're giving to somebody with a healthy heart. Now, heart failure makes the person prone to excessive buildup within the heart, and then that fluid can build up and go out backwards and out into the pulmonary system. So there are some meds that can actually contribute even further to that problem, including steroids. Steroids are contraindicated in heart failure. It's a relative contraindication. Obviously, the benefits and risks need to be weighed, but it can really it can lead to a fluid overload. So a few things to think about when we're thinking about the patient with heart failure. With heart failure, we want to teach less than or equal to 2 grams of sodium a day. A low-fat, low-cholesterol diet is still recommended. We're making some headway and some changes with that, but that's what you're still learning. Exercise, no alcohol. There is some contraindicative research to wine prior to having heart failure, but once you have heart failure, then that becomes part of the no alcohol thing. And then stop smoking. We talk about one of the oldest heart meds that are out there, which is digoxin or digitalis. It's a cardiac glycoside. So it's a positive inotrope. So it means that it's going to make that heart squish better, and the stroke volume is going to be better. It's a negative chronotrope, so it's going to decrease that heart rate. So thinking about those things, we need to remember that with DIG, we need to check that apical pulse rate before we give it. If the apical pulse rate is less than 60, we need to hold it. And then if we hold something and we don't have parameters to hold it, we need to call the doctor. Now, the other thing that we would report to the doc would be yellow halos or blurred vision. This can indicate DIG toxicity, and we'll need to check DIG levels in that patient. Digoxin can be used for atrial fib, atrial flutter, and overall improvement of cardiac output in CHF patients. There's another drug that does this. It's called milrinone or Primacor. It's a phosphodiesterase inhibitor. It's, again, a positive inotrope, so it's making that stroke volume a whole lot better. Treats acute heart failure. It's administered IV for no longer than 48 to 72 hours, usually, to avoid severe cardiac dysrhythmias. Other agents used to treat heart failure include the ACE inhibitors, the vasodilators, angiotensin II receptor agonists, diuretics, and beta blockers. You'll think, we use these to treat blood pressure, right? Correct. So to not put so much work on that heart, we do sometimes decrease that blood pressure so that the heart doesn't have to work as hard to push the fluid out against the peripheral vascular system. We can use vasodilators in heart failure and in cardiac situations to decrease the amount of venous return, decrease the preload, decrease oxygen demand. Therefore, we're decreasing the afterload. We're improving kidney perfusion and improving skeletal muscle perfusion, even in these patients that have issues with that. So, ACE inhibitors we spoke of earlier, but we're speaking of them again because we do use these as a cardiac med also. And we also talked about using them merely for blood pressure before. These are the angiotensin converting enzyme inhibitors. They dilate small vessels, improve renal perfusion, decrease blood volume, decrease preload, decrease the release of aldosterone. They often end in pril, things like benzapril, captopril, enalapril, fosinapril, and the most famous one, lisinopril. They're famous for causing a dry cough due to bradykinin accumulation in the lungs, which is a partial inflammatory response in the lungs. And they also can cause some angioedema, which is some localized inflammation and swelling that can happen. If people experience the angioedema or the bradykinin cough, they need to be changed to something else. They can't continue taking an ACE inhibitor. And the thing that we usually change them to, not always, but oftentimes, are angiotensin II receptor blockers. These are the sartans, like valsartan and candesartan. They're approved for heart failure patients who cannot otherwise take the ACE inhibitors. Diuretics are always the first line treatment. I don't want to say always because I can't honestly always say always, right? But very often they're the first line treatment for reducing fluid volume. We will talk about spironolactone as a diuretic shortly. Beta blockers we've spoken of 100 times in this class now. You should know that they end in OLOL. Watch heart rate and blood pressure. May need to hold if the above are too low. So if your blood pressure is systolically 100 or less, you should question that patient taking that beta blocker. If the heart rate is 60 or less, we should be questioning that, if they should really be taking that. We need to hold this. So if you run into those issues, you hold and then you call the doc. The beneficial heart failure effect is seen in 1 to 3 months, although the beneficial blood pressure reduction is seen pretty much right away. Atrial natriuretic peptide is basically like BNP. You've heard of pro-BNP. So this is an exogenous product that's much like the endogenous BNP that we release. All right, so the atrial natriuretic peptide causes vasodilation, natriuresis, and diuresis. It was used in acute decompensated heart failure. Oftentimes, we're using milrinone at this time. Types of antianginal drugs include the beta blockers, the calcium channel blockers, and the nitrates. The beta blockers decrease the workload of the heart and decrease oxygen demands. Calcium channel blockers decrease the workload of the heart and decrease oxygen demands. Nitrates, they reduce venous tone, decreasing the workload of the heart, and they vasodilate, including opening up those coronary arteries. And so nitro is a real good example of a nitrate. Nitrates are the first line for angina. It results in vascular vasodilation, coronary and general. Side effects are headache and hypotension. The headache is to be expected, okay? And when a person is taking this at home, they should be told that if they need to take it at home for chest pain, they should sit down or lie down first, because you'd hate to have someone become hypotensive and then all of a sudden fall and hit their head. So if you're giving nitro and the patient says, oh my goodness, I have a headache, do you stop the nitro and discontinue it? Absolutely not. In fact, when you give the nitro, you can let the patient know you're going to experience a headache, but they're pretty appreciative to have the headache when they know that it's actually something that is going to save some of their heart muscle. So when provider is prescribing Cialis or Viagra, they'll need to know if someone has nitrates, has nitroglycerin, or is on any other sort of a nitrate at home. Because if someone has Cialis in their system and they take a nitro, the two of them are going to combine and cause a marked hypotension that's really dangerous. In the hospital, functionally, when somebody comes in with chest pain, get that IV going right away and get that nitro in, and have that bag of fluid already hanging when you give that nitro, because there are certain types of heart attacks where you'll have a significant drop in blood pressure after having given nitro, and you'll need to open up fluids and get that blood pressure up. Beta blockers block the action of catecholamines, epinephrine and norepinephrine, and we've talked about these 100 times, right? They decrease the heart rate and the blood pressure. We should know to tell patients do not abruptly discontinue, and they can be selective or non-selective. And we've talked about that before. Selectives go just for the beta 1s. Non-selectives go beta 1 and beta 2, so you have more of a risk of wheezing and lung issues with that for somebody who has, say, asthma or COPD. Hold beta blockers if the blood pressure is too low, and hold if the pulse is less than 60. Too low of a blood pressure, oftentimes that's below 100. You want to seek some advice whether you should give that or not. Then, last but not least, are the calcium channel blockers. So these can be used for variant and stable angina. So these are often given, they're much better prophylactic. They're not like nitro, which is given in the heat of the storm of the angina. So they decrease cardiac oxygen demand and contractility. They decrease preload and peripheral resistance. Examples include amlodipine, diltiazem, nicardipine, nifedipine, and verapamil. Again, they also decrease heart rate and blood pressure. So this can help you later on when you are working on your NCLEX. It shows you the calcium channel blockers and the beta blockers, potassium channel blockers, some other types of things that are used on the heart as antidysrhythmics, and what their side effects can be. So it's kind of neat.